Dr. Uzo is presenting a topic, Principles of Surgery in the Elderly. It's supposed to be moderated by Dr. Adigije, but I think he did not remind his moderator. The presentation is actually supposed to be last week, and it's carried on to this week. So you should have reminded him. But notwithstanding, we are going to continue with the presentation. So Dr. Uzo, you can go ahead and start your presentation.
Okay, thank you very much, sir. Good evening, everyone. Today, Dr. Uzo CJ, a registrar in FMC Jabi. I'll be taking the topic, the principles of surgery in the elderly. I'll be following this outline to discuss. Can you all hear me, please?
Yes, we can hear you.
Okay, I'll be following this outline. I'll start by introducing the topic, then talk about the peculiarities in the elderly, then I'll talk about the preoperative care, then intraoperative care, post-operative care, then I will conclude. So as a mode of introduction, most developed world countries have accepted the chronological age of 65 as a definition for elderly or older person. But like many westernized concepts, this does not adapt well to the situation in Africa. While this definition is somewhat arbitrary, it is many times associated with the age at which one can begin to receive pension benefits. At the moment, there is no United Nations standard numerical criterion, but the UN agrees a cutoff of 60 plus years to be referred to the older population. Although there are commonly used definitions of old age, there is no general agreement to the age at which the person can become old. The common use of a calendar age to mark the threshold of old age assumes equivalence with biological age. Yet at the same time, it is generally accepted that these two are not necessarily synonymous. That means someone might be chronologically 65, but physiologically the person isn't or might be way older than 65. Realistically, if a definition in Africa is to be developed, it should be either 50 or 55 years of age. But even this is somewhat arbitrary and introduces additional problems for data comparability across nations. But according to WHO, chronological old age is also classified as follows, as 65 to 75 years defined as a young old age and a transition period from work life to retirement. The second category is 75 to 85 years, which is defined as advanced old ages and a period where functional losses begin to be observed. Then we have the third category as 85 years and older, which is defined as very advanced old ages and a period that requires special care and support. Now, going on to the peculiarities in the elderly, I would talk about them systematically. I'll try to expand the peculiarities that are associated with the elderly patients. Now, starting with the cardiovascular system, we have the heart. The cardiac output in the elderly decreases linearly after the third decade. The cardiac output decreases linearly after the third decade at the rate of about 1% per year in normal subjects, otherwise free of cardiac diseases. And due to the small decrease in surface area with age, the cardiac index falls at a slightly slower rate of 0.79% per year. The cardiac output of an 80-year-old subject is approximately half that of a 20-year-old. The basis of this decrease in cardiac function is unknown, but however related to one of several factors, which I'm going to talk about in the next slide. Now, the senescent cardiac muscles, that's cardiac muscles of the elderly, have a decreased inotropic response to catecholamines, both endogenous and exogenous, and perhaps more clinical significance is a decreased response to cardiac glycosides. Aging is associated with increase in diastolic and systolic myocardial stiffness due to increased interstitial fibrosis of the myocardium. As the myocardium is aging, there's an increase in fibrosis within the myocardial muscles. There's also a progressive stiffening of arteries with age, particularly of the thoracic aorta, leading to an increased afterload of the heart. Hypertension, which is more common, commonly associated with the elderly, there is a progressive increase in blood pressure after the first decade of life. It has long been regarded as a normal consequence of aging and was the basis for ignoring the presence of hypertension in the elderly. Only in the last past decade or so have prospective studies provided evidence of the grave potence of hypertension for the older age group, as well as the young, and the potential preventive values for early treatment. The elevation with age is more pronounced for systolic than with diastolic pressures. A Framingham study clearly established that high blood pressure is a significant risk factor for stroke, coronary artery diseases, and congestive heart failure. It is a significant cause of mortality in patients from 65 and above. Atherosclerosis and coronary artery diseases. Thickening of the walls of arteries and hyperplasia of the intima, collagenization of the media, and accumulation of calcium and phosphate in elastic fibers progressively occur with aging. In addition, the lipid content of non-atherosclerotic portions of vessels increases, particularly of cholesterol. Now, this slide is just talking about the changes that happen within the blood vessels as one is aging. These include collagenization and loss of elasticity of the blood vessels with lipid accumulation and atherosclerosis, which commonly occurs with aging. In general, atherosclerosis occurs earlier in the aorta and the carotid arteries than in the coronary and the cerebral arteries, and peripheral vascular disease appears later on. Myocardial infarction from coronary artery disease increases dramatically with age, and although many risk factors are known, age itself is probably the most significant. That means with all the risk factors associated with myocardial infarction, age is the most significant factor. Prevention at present is aimed at amelioration of other factors, which include hypertension, obesity, and cigarette smoking. Then we have the respiratory system. The respiratory system, we have the lung volumes. There are alterations in the lung volumes of the elderly. Now, this slide is just talking about the reduction in some lung volumes. For example, although the total lung capacity of elderly patients remains the same, we have the residual volumes which tend to be affected in the elderly patients. Most studies, the functional residual capacity also increases, although not as rapidly as the residual volume. Gas exchange in the elderly. Although alveolar oxygen tension remains constant with age, arterial oxygen pressure shows a progressive decrease, thus increasing the alveolar arterial oxygen difference. Most of this decrease in arterial oxygen pressure results from a mismatch of ventilation and perfusion. Due to changes in the respiratory system, the gaseous exchange tends to differ between the elderly and the young patients. We have the elastic cause of the lungs decrease with age, and thus there is greater tendency for airway collapse. This is measured as an increase in enclosed volume, which increases linearly above the age of 20. Then flow rate, there is a 20 to 30 increase in maximum voluntary ventilation, first expiratory volume in 1 second, maximal expiratory flow rate, and maximum mid-expiratory flow during adult life. The basis for these changes is not known, but again may be related to the decrease in the elastic recoil properties of the lungs. Infections. It is well known that elderly patients have a pronounced increase in incidence of pneumonia, both bacterial and viral, compared to younger persons. Although much of this may be due to general depression of the immune system function, pneumonia generally results from aspiration of oropharyngeal secretions, and such aspirations appear more frequently in the elderly. Now, in the elderly, they are more prone to aspirations due to decreased sensitivity for for swallowing. Their swallowing reflexes dwindle over the years due to neuronal losses. So eventually, even with changes in the esophagus, which I will talk about subsequently, they are prone to aspirations into the respiratory system, and of course, further pneumonia, having pneumonia. The normal mechanical clearing of the tracheobronchial tree by the mucociliary apparatus is significantly slower in non-smoking older persons than in the younger counterparts. That means the mucociliary apparatus that usually clears out the airways, with age, they tend to lose their function and thereby predispose the elderly to infections and aspirations. Finally, due perhaps to poor oral hygiene, decreased flow of saliva, or difficulty with swallowing, older persons have a higher rate of colonization of their oropharynx with gram-negative bacilli than do younger persons. Then the genitourinary systems, then the kidneys, a gradual decrease in the volume and weight of the kidneys occur with aging, so that by the 9th decade, renal size is about 70% of that of the 3rd decade. Moreover, there is a decline in the total number of glomeruli per kidney from about 1 million below the age of 40 to about 700,000 by the age of 65. With a reduction in the number of glomeruli, there is a concomitant age-related decrease in the creatinine clearance, and the decline is according to the following equation, which is creatinine, which is in mils per minute, is equals to 135.0 minus 0.84 times age in years. The serum creatinine concentration, however, changes little with age, even though with the decrease in the amount of creatinine clearance with advancement in age, the serum creatinine concentration doesn't really change so much. The attrition of renal function has significant consequences for the clinical management of elderly patients with especially drug clearance, for example, aminoglycosides, digoxin, penicillins, and tetracyclines, which are primarily cleared by glomerular filtration. They would therefore have a prolonged half-life in the elderly patients because of the loss of glomerular filtration power and concentration. So these drugs tend to have a prolonged half-life in the elderly patient. So when dosing these patients, is appropriate to modify the doses of such drugs. One study showed that the half-life of these drugs in older patients with a normal serum creatinine concentration was about twice that in a younger person. For the bladder, the older patient usually come down with a lot of urinary incontinence. This has been found in 17% of men and 23% of women older than 65 years. In about half of the women and a fifth of the men, this was due to stress incontinence alone. These effects have been found to be as a result of central nervous system disease than to bladder dysfunction. In the gastrointestinal system, the elderly patients have age-related changes in the esophagus. This is also called, or can be called, presbyosophagus. They are primarily due to disturbances in esophageal motility. The esophagus in an elderly patient may have a decreased peristaltic response, an increased non-peristaltic response, a delayed transit time, or a decreased relaxation of the lower sphincter on swallowing, thereby leading to slower transit of food from the mouth to the stomach, and also can form a bag to collect food and lead to subsequent aspiration into the respiratory system. The decrease in peristalsis and delay in transit time may lead to dysphagia with a voluntary curtailment of caloric consumption. Non-peristaltic contractions are found almost exclusively in the elderly. That means contractions, the elderly patients are prone to contractions in the esophagus that are non-peristaltic. In the stomach, there's incidence of atrophic gastritis. This increases significantly with age. In a Scandinavian study, approximately 40% of apparently healthy individuals older than 65 years had evidence of atrophic gastritis, thereby predisposing them to ulceration, that's peptic ulcer disease, ulcer formations, and worsen response to colon ulcer, that's to trauma. They are more exposed to ulcers. In the colon, there's a decrease in intestinal motility, which occurs with age. The colon becomes hypotonic, which leads to increased storage capacity, longer stool transit time, and greater stool dehydration. These are all etiological factors in the chronic constipation that plagues the aged. Laxative abuse, therefore, results in most common causes of diarrhea in the elderly. Now, in the elderly, there is usually loss of control of the internal and external anal sphincters, and there is a presence of essentially normal, even in the presence of essentially normal cognitive function. And this is mostly emotionally traumatizing and a demeaning experience for the elderly. Although tests of liver function shows little or no change in the elderly, a large number of drugs such as diazepam and antipyrines are known to be metabolized more slowly by the liver in the elderly. Now, the endocrine system of the elderly, glucose homeostasis, increasing age results in a progressive deterioration in the number and the function of the insulin-producing beta cells. The capacity of these cells to recognize and respond to changes in glucose concentration is therefore impaired, thereby predisposing the elderly patients to diabetes. Slight hyperglycemia causes a chain reaction which can lead to coma or death because of disturbances in insulin action and metabolism. Talking about the skin of the elderly, they are usually plagued with atrophy. There's atrophy of the epidermis, which atrophy of the epidermis occurs with age and is most pronounced in exposed areas. These include the face, neck, upper arm, upper part of the chest, and extensor surfaces of the hand. These areas are usually more exposed to sunlight, and as we all know, UV rays tend to cause aging, loss of elasticity, and changes in the epidermis. These changes are more pronounced with elderly patients. In addition to the thinning of the epidermis, there is notable flattening of the dermal-epidermal junction with effacement of both the dermal papillae and the epidermal reti pegs. The turnover rate of cells in the stratum corneum decreases with age, and in persons older than 65, it takes about 50% longer to reepithelize blistered skin than in younger adults. Now, the dermis, the dermal collagen becomes stiffer and less pliable with age. Elastin is more cross-linked and has a high degree of calcification. These changes cause the skin to lose its tone, elasticity, resulting in sagging and wrinkling. An age-related decrease in the number of dermal blood vessels also develops. The relative ischemia of the skin may also play a pathogenic role in the development of decupitous ulcers. The associated skin changes results in difficulty in getting peripheral venous access, which is mostly seen in elderly patients. It's difficult to cannulate to get intravenous access in elderly patients because of these skin changes, which I just mentioned. Now, the musculoskeletal system of the elderly, this is also an important part in the elderly because of positioning of these patients and their overall well-being. There is a degenerative disease of all types affect the elderly, and arthritis is almost universal. This may limit exercise tolerance and make it difficult to assess fitness in these elderly patients. Osteoporosis and ligament laxity makes epidural and spinal injections technically difficult. In addition, the patient is prone to fractures or dislocations of joints, including the cervical spine, while anesthetized. Care should be taken with such patients during movement and intraoperative positioning. Vulnerable pressure points should be well padded. This to prevent decupitous ulcer formation. Now, the central nervous system of elderly patients, an age-related decline in central nervous system function is common, the cause of which includes cerebrovascular disease, changing in hormone levels, neuronal damage induced by oxidative stress, as well as generalized progressive loss of cells. Now, with aging, there is a progressive loss of neuronal cells. As a result, confusion is more common, both pre and post-operatively. Cognitive impairment increases with aging, and dementia may affect up to 20% of patients over 80 years of age. Blindness affects nearly 30% of the elderly, largely due to cataracts and glaucoma, and may make understanding written materials such as consent forms and visual analog pain scales very difficult. Deafness is also common in the elderly and may be severe in about 35% of elderly patients. Autonomic dysfunction is also more prevalent in the elderly population and may result in labile blood pressure and arrhythmias perioperatively. The baroreceptor reflex may be attenuated, leading to postural hypotension and a drop in blood pressure during anesthesia, particularly during induction in a relatively hypovolemic patient. There is impaired temperature regulation and delayed gastric emptying, which also may occur. Now, the next point I'll talk about is the geriatric syndromes, because in all elderly patients, or in most elderly patients, they usually come with a cluster of symptoms. So I'll talk about them under this topic as geriatric syndromes. This term is used to describe clinical conditions that do not fit into discrete disease categories, but can substantially negatively impact the quality of life and result in disability. Now, the syndromes include frailty, falls, delirium, malnutrition, dizziness, syncope, urinary incontinence, pressure ulcers, and among others. Now, talking about frailty is a chronic progressive condition that represents a spectrum. Less frail individuals may be responsive to strategies or interventions to ameliorate its clinical manifestations, while more frail individuals may demonstrate an irreversible pre-death condition with limited life expectancy. Definition of frailty falls into two broad models. There's a phenotypic model and a deficit accumulation model. This is a chart talking about the criteria at which frailty is defined. The criteria include weight loss, exhaustion, physical activity, walk time, grip strength. In the next slide, I will show a diagrammatic presentation of the phenotypic frailty phenotype. A weight loss of greater than 10% in 6 months, excessive exhaustion, slow gait speed, weak grip strength, and low energy. For patients that have excessive weight loss in the past 6 months, or are easily exhausted, or have these 5 categories are put in the frailty spectrum. And in that frailty spectrum determines the prognosis of is a high prognostic factor in managing the elderly patients. That's basically what the frailty spectrum talks about. This is another diagram showing the cumulative deficit frailty. When I talked about the models at which frailty is being recognized, I talked about the phenotypic method and the cumulative deficit frailty. This is the cognitive function of the patient, apart from the physical appearance of the patient. Now, talking about the cognitive function, we talk about the mobility, cognition, mood, social vulnerability, diseases, nutrition, and the energy. In this model, we look at these factors and extrapolate the prognosis of elderly patients when we are preparing them electively for procedures. Now, delirium. Delirium is a disorder of attention and awareness that develops acutely and tends to fluctuate, as defined by the New Diagnostic and Statistic Manual of Mental Disorders. Falls. Multifactorial etiologies. The multifactorial etiologies that cause falls include age-related decline, chronic medication use. Preoperative falls have a direct link to increased post-operative morbidity and mortality. Now, elderly people are at risk of complications, and the complications associated with elderly people can be grouped into two groups, which are patient-specific or the nature of the procedure. Now, talking about patient-specific risk, patients with dementia have increased risk of delirium post-operatively, and this also affects their post-operative care and the outcome. Diabetes and renal diseases, those are comorbidities which include diabetes, renal diseases, vascular diseases, patients with COPD, those that smoke and have uncontrolled asthma. Malnutrition is also a patient-specific risk factor, and level of activity or functional capacity. These are associated with increased cardiovascular risk. Now, the nature of procedures. The nature of procedure that elderly people are exposed to can be classified further into two. That's emergency procedures and elective procedures. Now, in the elective procedures, we have the high-risk procedures, intermediate risk procedures, low-risk procedures. Now, the high-risk procedures have the highest risk, or they have the poorest prognosis for elderly patients. They include major vascular surgeries, that's emergent surgeries, which are also high risk, and those with increased blood pressure are at high risk procedures for cardiac complications. Then we'll have the intermediate risks surgeries, which include intra-abdominal, intra-thoracic, orthopedics, and carotid. Orthopedic procedures, we have carotid end atherectomy. They are associated with 1% to 5% incidence of cardiac complications. Then we have the low risk procedures, which include superficial surgeries, endoscopy, breast lump excisions, cataract surgeries. They are low risks. They are also associated with less than 1% risk of cardiac complications post-surgery. Now, the preoperative evaluation of elderly patients. This is a checklist for optimal preoperative assessment of geriatric surgical patients. In addition to conducting a complete history and physical examination, the following are strongly recommended. Assess the patient's cognitive ability and capacity to understand the anticipated surgery. The patient is screened for depression. We identify the patient's risk factors for developing post-operative delirium, which I will talk about later. We screen for alcohol and other substance abuse and dependence. Identify the patient's risk factors for post-operative pulmonary complications and implement appropriate strategies for prevention. Document functional status and history of falls, because falls have a role to play with post-operative care of this patient. Now, we also determine baseline frailty score, assess patient's nutritional status, and consider preoperative intervention if the patient is at severe nutritional risk. Take an accurate and detailed medication history and consider appropriate preoperative adjustments. We also determine the patient's treatment goals and expectations in the context of the possible treatment outcomes. Determine patients' families and social support system. Sorry, that's a mistake. Other appropriate and preoperative diagnostic tests focused on elderly patients. Now, the preoperative assessment in a nutshell include the functional assessment of the patient, frailty assessment, cognitive and behavioral assessment, medical assessment, that's medication assessment, nutritional assessment, psychosocial considerations, medication review, and patient counseling. Now, during the preparation, the patients, the peculiarities with preparing elderly patients would include: one, the patients are usually admitted close to the surgery date. This reduces the chances or the occurrence of nosocomial infections. There is a multidisciplinary invitation. That means elderly patients are managed via a multidisciplinary approach. Peripheral venous access should be changed 24 hourly to prevent sepsis or sepsis with intravenous access focus. There's a preoperative workup which includes routine blood investigations, clotting profile, because most elderly patients are usually on anticoagulant therapy, cardiovascular system workup, deep venous thrombosis prophylaxis, investigations in respect of the patient's comorbidities, which are gotten from the proper history taking and examination, strict nursing care, preoperative fasting. Preoperative fasting in the elderly, because they have issues with glucose metabolism. The patients should not be fasted more than 8 hours to prevent patients from entering hypoglycemia, or when they are placed on preoperative fasting, IV access with glucose-containing fluids are given to them. Use of adjuncts where indicated, like catheterization. Elderly patients, for proper urine monitoring, they should be catheterized where necessary. Proper counseling and obtaining informed consent. Now, to obtain an informed consent from an elderly patient, it is paramount to always have their relatives present. So, because most times elderly patients come down with cognitive impairment, so they might not really understand the gravity or really understand the management and the procedures that are following that follow up. Sorry. Obtaining an informed consent. Before obtaining the surgical consent, the surgeon should determine whether or not the patient has decision-making capacity. The 4 legally relevant criteria for decision-making capacity are: the patient can clearly indicate his or her treatment choice, the patient understands the relevant information communicated by the physician, the patient acknowledges his or her medical condition, treatment option, and the likely outcome. The patient can engage in a rational discussion about the treatment option. So these are the 4 legally relevant criteria for decision making when taking informed consent from elderly patients. Now, the nutrition of elderly patients. All patients should be evaluated for their nutritional status. Their heights and weight should be documented and their body mass index well calculated. Measure baseline serum albumin and prealbumin levels. Inquire about unintentional weight loss in the past year. Remember when I talked about the frailty phenotypic model, weight loss in the past usually 6 months. Document patients with severe nutritional risk if they exhibit any of the following: patients with BMI less than 18.5 kilograms per meter squared, serum albumin less than 3.0, and unintentional loss greater than 10 to 15% within 6 months. Poor nutritional status is associated with increased risk of post-operative complications. Preliminary evaluation of elderly patients. There is no definite predictor of who with lung disease should proceed with surgery. Testing is directed to defining disease states and optimizing status prior to proceeding with surgery. So preliminary evaluation in elderly patients is just to know those that can actually go forth into surgery, or those that would actually need more stabilization, especially patients with COPD and patients with asthma. They need further stabilization before they can go into surgery. Consider baseline arterial blood gases and chest X-ray. Consider preliminary function tests before and after treatment to optimize function. In overweight patients suspected of obstructive sleep apnea, sleep studies may be warranted. Now, the risk factors for post-operative pulmonary complications can be divided into patient-related factors, surgery-related factors, and non-risk factors. The patient-related factors include the age, presence of COPD, that's chronic obstructive pulmonary disease, patients that are on functional dependence, patients with congestive heart failure, patients with obstructive sleep apnea, current cigarette use, weight loss greater than 10% in 6 months, serum albumin less than 3.5 milligram per DL. Then the surgery-related factors that expose patients to post-operative pulmonary complications include prolonged operation greater than 3 hours, surgical sites, sites that have to do with a long midline scar can affect breathing in such patients and predispose them to post-operative pneumonia. Emergency operations, general anesthesia. General anesthesia predisposes the elderly patients to lung collapse. And we have perioperative transfusion, residual neuromuscular blockade after an operation. The other risk factors include obesity. Okay, sorry, that's a mistake. Non-risk factors: obesity, well-controlled asthma, and diabetes. These are the factors that can predispose the elderly patient to post-operative pulmonary complications. Preoperative strategies to prevent pulmonary complications include preoperative optimization of pulmonary function in patients with COPD and asthma that is not well controlled, which I spoke about earlier. Patients that should stop smoking 4 to 8 weeks before the surgery. Preoperative intensive inspiratory muscle training. This is done by the physiotherapist. A selective chest radiograph and pulmonary function test, although this is not routinely done for all patients. Now, for the cardiovascular system, cardiac evaluation for non-cardiac surgeries is graded into 5 steps. For emergency surgeries, you have to just proceed with surgery with medical risk reduction and perioperative surveillance. For patients with an active cardiac condition, such as unstable coronary syndromes, decompensated heart failure, significant arrhythmias, severe vascular diseases, the surgery is postponed till the patient is well stabilized. Now, for low-risk surgeries with risk less than 1%, example, superficial or endoscopic surgeries, cataracts or breast surgeries, ambulatory surgeries, you can proceed to surgery, and so on and so forth. So for medication evaluation, a patient's complete medication list should be known, including over-the-counter medications, supplements, vitamins, herbal agents. This should be reviewed and documented. Discontinuation of non-essential medications in elderly patients, continuation of essential medications. Planning for the resumption of all other baseline outpatient medications in the post-operative period with consideration for minimizing polypharmacy risk. Now, drugs with anticholinergic properties such as diphenhydramine or meclizine can increase the risk of perioperative delirium and should be withheld or discontinued. Holding diuretics for 24 hours prior to surgery should be considered if there is no need to treat excessive volume or symptoms of pulmonary congestion in patients with heart failure. That means the patients with heart failure that are well compensated, diuretics are not indicated 24 hours prior to surgery. Now, patients on anti-epileptics, cardiovascular drugs, and antihypertensive medications typically should take their medications on the morning of the surgery. Medications for seizure disorders, Parkinson's disease, and agents for myasthenia gravis should be continued throughout the perioperative period to minimize the risk of worsening neurological symptoms. Abrupt discontinuation of beta blockers and clonidine is associated with significant cardiovascular complications. Patients using these medications should therefore be managed with intravenous metoprolol or transdermal clonidine patches, if unavailable, to resume oral intake post-operatively. If unavailable, if transdermal clonidine and intravenous metoprolol patches are not available, patients are encouraged to resume oral intake post-operatively. Angiotensin converting enzyme inhibitors and angiotensin receptor blockers are commonly held in the morning of surgery to avoid known risk of hypotension upon induction of anesthesia. Other drugs like oral hypoglycemias are generally held the night prior to surgery to prevent hypoglycemia intra-op. Patients who require insulin typically receive 50 to 80% of their usual dose of baseline insulin on the morning of surgery. Drugs like metformin should be suspended a day before with procedures that are used intravenous contrast because of the increased risk of metabolic acidosis in such patients with renal impairment. So patients on metformin with some form of renal impairment, metformin usually stopped 48 hours before or and after the procedure. Now, patients on anticoagulants like aspirin, clopidogrel, non-steroidals, and other antiplatelet drugs increase the risk of perioperative bleeding, and if not essential, should be held for a recommended 5 to 7 days. Now, patients on chronic warfarin with an INR goal of 2 to 3 should be withheld to allow INR to fall below 1.5 before the surgery. If the INR is typically kept above 3, then longer periods without a warfarin dose may be required. The INR should be measured on the day of surgery to ensure that it has reached the acceptable range of below 1.5, or supplemented vitamin K can be given to bring it to this level, usually within 24 hours. Now, if rapid reversal of INR is required, fresh frozen plasma can be given to bring the INR to below 1.5, and patient can now go in for operation. When the INR is less than 2.0, other prophylactic antithrombotic intervention can be considered. Now, elective surgery is best avoided for at least 3 months following a deep venous thrombosis or pulmonary embolism effect to ensure adequate duration for anticoagulant treatment. If this is not possible, then anticoagulation bridging with low molecular weight heparin should be given before and after the procedure for patients on warfarin, while INR is less than 2.0. What this basically means is patients on anticoagulant therapy that have had a deep venous thrombosis event or pulmonary embolism event within the last 3 months that still need to have elective surgeries can have a transition from warfarin to low molecular weight heparin. This is known as anticoagulation bridging. This is indicated in special circumstances in patients that have metallic heart valves, venous thromboembolic episode within the last 3 months, as I said earlier, patients that have had cardiac thrombus, patients that have had stroke or transient ischemic attack due to atrial fibrillation. This is what I talked about the anticoagulation bridging. Now, preoperative delirium assessment, because these patients are prone to delirium post-op, there are certain factors or there are certain risk factors that are washed out or that are present that increases the patient's risk of having post-operative delirium. These include age greater than 65, visual or hearing impairment, pre-existing cognitive impairment, severe illness for those that need ICU admission, presence of infection, depression, alcohol abuse, current hip fracture, renal insufficiency, anemia, poor nutrition, limited mobility, unintentional injury, example, falls. These are the risk factors that predispose the elderly patients to post-operative delirium. Now, drugs associated with increase of post-operative delirium include anticholinergics, meperidine, CNS stimulants, and those that abuse alcohol. Now, the technicalities in the elderly. Technicalities of the elderly include the elderly patients have poor health-seeking behaviors. They are usually associated with missed clinic days. They have issues with late presentation because they're usually alone, and most of the time they even forget their clinic appointment days. There is difficulty in getting appropriate history from the elderly patients because many of them are plagued with cognitive impairments. There is usually maxing of clinical signs. For example, their immunity is low. A lot of them experience low immunity and don't when in cases of sepsis, they don't have the clinical signs of people that are septic. There are usually conflicting decision making. For example, patients that want to go in for it's usually common with patients that need some form of amputation. There are usually conflict of decision making between the patients and patient relatives. Intravenous access is difficult due to loss of skin elasticity, as I talked about in the skin changes associated with the elderly. Now, intraoperative management or intraoperative care of elderly patients. The anesthetic approach consideration of regional techniques to avoid postoperative complications and improve pain control. Perioperative analgesic plan. Perioperative analgesic plan directed pain history, multimodal or opioid sparing techniques are considered for regional techniques. Postoperative nausea risk stratification and prevention strategies. These are all the anesthetic approaches for elderly patients. The use of short-acting muscle relaxants and restrict benzodiazepine use and opioids because of the risk of post-op delirium, as I mentioned earlier. Now, the difficulty, the anesthesia, the peculiarities in the elderly from the anesthetic point of view include difficulty in assessing spinal anesthesia due to degenerative bone diseases, difficult intubation due to cervical spine degeneration, dose adjustment for medication due to reduced physiologic clearance. Now, positioning of the patient, there is difficulty due to bone degeneration, fracture and dislocation predisposition in the elderly, and they suffer from joint stiffness and deformity. Now, the elderly patients are exposed to intraoperative hypothermia, which is the temperatures less than 36.0. The elderly in particular are predisposed to hypothermia due to altered thermoregulation from decreased bone mass, decreased metabolic rate, and decreased vascular activity. Hypothermia is associated with adverse events in the surgical patient, including surgical site infection, cardiac events, coagulopathy leading to surgical bleeding, and increased oxygen consumption due to shivering. The core temperature should be monitored in surgeries lasting more than 30 minutes. Fluid and electrolyte balance is very paramount in elderly patients. Elderly patients, intraoperative care of the elderly patient should be purely aseptic. The principles of operative should be followed, avoiding prolonged surgery time because of the reduced physiologic capacity of elderly patients. Hemostasis must be ensured. Limit the use of drains because they restrict mobility and predispose patients to they increase hospital stay, predispose patients to nosocomial infection, predispose the patient to sepsis, predispose the patients to deep vein thrombosis because of lack of restricted mobility. Then strict adherence to principle of antibiotic use. Now, for post-operative management, the post-operative problems of the elderly include the increased risk of deep vein thrombosis because of mobility. There's increased risk of delirium. There are increased risk of lung collapse in the elderly patients, paralytic ileus, nosocomial infections, which include from the pulmonary tract and urinary tract infections. They are more prone to decúbitus ulcers, and patients are usually lost to follow up. Most times, most of these elderly patients, after their treatment, they retire to their villages and they are lost to follow up. They just prefer to just stay with family. And from there, they are usually lost to follow up. Now, also post-operative care of elderly patients would include pain management, delirium monitoring, early ambulation, bowel management, falls prevention, pressure ulcer prevention, prevention of pulmonary complications, transition of care following the perioperative period. Now, for pain management of elderly patients, the use of opioid-sparing techniques, which may include perioperative, intraoperative, and/or scheduled post-operative acetaminophen, or the addition of regional techniques such as neuraxial blockade or peri-nerve blocks. They will benefit more from opioid-sparing techniques. Avoid potentially inappropriate medications as defined by the American Geriatric Society. Bears criteria. Common analgesics and anxiolytics to avoid include barbiturates, benzodiazepine, non-benzodiazepine hypnotics, and so on. Then prevention of post-operative constipation, gentle handling and minimal manipulation of the bowel of the intestine. Pain management. Opioids should be used sparingly and supplemented with NSAIDs and other non-opioid relievers. Because of the reduced gastric emptying time in the elderly patients, opioids tend to worsen constipation. Maintenance and replacement fluid therapy, correct electrolyte imbalances because they are prone to paralytic ileus. Early oral feeding and early mobilization, achieve normalization of gastrointestinal function within 48 hours in most patients. Chewing gum post-operatively also stimulates bowel movement. So these are post-operative strategies to prevent pulmonary complications in the elderly. They include aspiration precautions, which include bedside evaluation of any patient with symptoms, signs, or history of dysphagia. The patients with history of dysphagia are prone to aspiration, so they should have proper bedside evaluation. Instrumental swallowing evaluation in selected patients. Head of bed elevation at all times with repositioning. Getting out of bed for all meals when possible. Sitting upright while eating. And for 1 hour after feeding. Use of incentive spirometer and chest physical therapy. This is where the physiotherapists also come in. Use of deep breathing exercises and the use of epidural analgesia. These are the post-operative strategies to prevent pulmonary complications. Now, for venous thromboembolism prophylaxis in high-risk groups, we have the use of low molecular weight heparin and intermittent compression socks. They are used to prevent deep vein thrombosis and thromboembolic episodes. This is just a table explaining for different categories of patients undergoing different surgeries. What is the recommended regimen for them? Then the universal fall prevention. For patients to prevent falls in elderly patients because they are prone to falls, the patient has to be familiarized with the environment, demonstrate call light use, maintain call light within reach. When these patients have started mobilizing, they should have some form of system to indicate for help if they need help. Keep personal position within reach. Study handrails in bathrooms, rooms, and hallways. Hospital beds in low position when patient is resting. Raise to comfortable height when patient is being transferred. Hospital bed breaks locked. Wheelchair locked systems when stationary. Non-sleep, comfortable, well-fitting footwear. Night light or supplemented lighting use. Keep floor surfaces clean and dry. Keep spills and clean spills promptly. Keep patient care areas uncluttered and follow safe patient. They should be a safe patient handling practice which should be followed at all times. That's to prevent falls in elderly patients. Now, we also have pressure ulcer prevention and treatment, which include turning patients every 2 hourly, avoid sliding patients across the mattress. This causes abrasion injuries, and use of low pressure air mattresses or air fluid chronic pressure shifting beds, high specification foam mattresses, consultation with psychiatry and/or physical therapy. This category reduces or minimizes pressure, friction, humidity, and shear forces. Now, restoration of nutrition and wound care. These are all the things that are done to prevent pressure ulcers in elderly patients. Now, in conclusion, surgery in the elderly is peculiar and more sophisticated due to the physiological and pathological age-related changes. The surgeon needs to be equipped with the associated conditions that plague advancement in age in order to prevent morbidity and mortality in these age groups. Thank you.
Thank you, Dr. Uzo. You don't have references?
Sorry, I don't know what happened to this slide. My references should have shown, but for some reason it did not.
Okay, it was a very researched topic, so I was really hoping to see the references you used, because there are some peculiar definitions. I would have loved to know where you got them from. But by and large,
yes, I would. Yes, sir.
Very researched topic, and I must acknowledge that you have done very well in the presentation, and the delivery of your information was smooth. So I can see most of the residents logged out. Dr. Chiamaka, you are with us. Do you have any question for Dr. Uzo?
Good evening, sir. No, sir. I have no questions.
Okay.
I think it was a well-detailed presentation, sir.
I agree. It's a well-detailed, well-researched, and as well-presented topic. So, but by and large, you did very well, Dr. Uzo.
Thank you very much, sir.
You should keep it up. When you have presentations like this, you might not have time to read the topic again. So the more you go to town in reading, the better for you. When you come to revise it, it's going to be easy. And of course, this is a very important topic in your exams, both part 1 and part 2 exams, and all specialties in surgery manage, except pediatric surgery. Any specialty you go into in surgery, not only general surgery, manage elderly patients. And the peculiarities of elderly patients, as you mentioned, is reduced physiology involving all the systems, and the increased stress of surgery and anesthesia with a patient who already has a diminished physiology will make you very cautious in the perioperative handling of fluid and drugs, because the body's ability to metabolize and excrete all these products is drastically reduced. So optimization in elective case and resuscitation in emergency case should be done with caution to prevent complication. This is a very important thing you need to know in this topic. And those specific problems like BP optimization, treatment of respiratory tract infection, and treatment of distance infection at distant site, and because of reduction in their effective circulating volume and also handling capacity of the kidneys, you have to be very, very serious with optimization of patient before surgery. And intraoperatively, you have to be as fast as possible, and also take care of the anesthetic drugs you give, as well as blood loss. You have to be very cautious. And the important point in the post-operative period will involve the early mobilization of the patient, early
Yes, sir.
physiotherapy and early nutritional commencement and rehabilitation. So by and large, you
Yes,
did
sir.
an excellent presentation. I must applaud you for that, and you should keep it up. So,
Thank
well,
you very much, sir.
thank you. So next week we'll continue with the presentation. Well done, Dr. Uzo. So we are going to stop here.
Thank you very much, sir.
You're welcome.